So really, we missed um, your talk in our meeting because every meeting here is canceled now because of the pandemic of the coronavirus pandemic. So I was caring. So I'm caring now to get the knowledge and to get the opportunity to talk to you and to listen to you today. And then I will share this meeting and this presentation with its contents and discussions to the others to benefit from it. And thank you,
That's
really,
great.
really thank you for your time and for your uh, uh, that you arranged time with me.
It's my pleasure to participate.
Okay.
So let's start.
Yeah.
Uh,
Yeah.
so
Start now.
so thank you for the opportunity, Dr. Ziada, and I'm looking forward to enhancing our collaborations with colleagues in Egypt like you. Highly respect the work you do, and we have many things in common and a lot to collaborate. So
Yes.
the topic is one of my favorite topics, which is enhanced screening for refractive surgery candidates and advances in refractive treatment for keratoconus, actually therapeutic treatments for keratoconus.
Yeah. Okay.
So um, I don't, I cannot advance. Okay. So I have always to acknowledge the commercial relationships, but I always say that my main relationship commercially is with my patients. And that's my obligation to do the best as possible. So it's very important that we keep that in our minds.
Yes.
With the collaborations that we have in Brazil and also in Portugal, uh, when we talk about this, it's really important that we understand the multimodal uh, screening for refractive candidates. Multimodal screening for refractive candidates is a very important concept that we should understand. The concept is that we should think about from slit lamp evaluation. Actually, let me just turn off this WhatsApp, otherwise with this annoying click.
Yes.
Yes, just a second. I'm back here. So digital slit lamp, central corneal thickness, placido disc topography, ocular surface imaging, tomography with the shine flug, and also with the OCT for segmental tomography, wavefront, ocular scattering, biometry, biomechanics and IOP, specular microscopy and confocal microscopy. They all give us important information for refractive surgery planning. It's not only corneal refractive surgery because we have to decide if inside the eye that's the best option, if phakic IOL or lens surgery, if the surgery is therapeutic, or eventually if you do the cornea, if you do surface ablation, LASIK, or SMILE. All of this will be important. And of course, the main bothersome complication that we have is ectasia. I know you have many ectasia patients in Egypt in your area because of the weather, because of the social genetic structure of the population. But we need to understand that ectasia is a complication that lead refractive surgery to promote a huge evolution. The evolution in screening, the diagnosis, and we'll discuss a little bit of the importance of the understanding that we have to go beyond, not over. Not over detecting mild cases of keratoconus, not over the understanding that topography is important but not enough. We have to understand the susceptibility for ectasia. And the first concept is that biomechanical decompensation of the cornea would occur based on two factors. The first factor is the innate biomechanical properties of the cornea, and the second one is the environment. That's like any disease. In medicine, we should understand that for anything. And impact from environment in laser vision correction procedures is going to be very important for the ectasia to develop after surgery. Of course, eye rubbing is very important. And the main concept is that any cornea may undergo ectasia. It's a very important topic that you should understand. So if we want to avoid ectasia, the first thing is to tell people not to rub the eye. And the keratoconus campaign that we that we have is that we we should make people understand that eye rubbing can cause any cornea to be unstable and biomechanically fail to develop ectasia. And telling people not to rub the eye is the first thing to do. The first ectasia was described in 1998. We know the literature, and the first report was actually on cases with high myopia that were treated with LASIK, and this patient developed ectasia because of the decompensation from the procedure. A few months later, Seiler published another report on ectasia after a patient, LASIK in a patient with form-fruit keratoconus, which was defined by the irregular topography. And the characterization of susceptibility should go beyond topography. And the main point is that topography is important. And I was honored to train my fellowship training in cornea surgery and refractive surgery with Steve Wilson, who did his fellow in LSU when Steve Kleiss and other colleagues, Herb Kaufman, Marguerite McDonald, they were working on the early days of refractive surgery and also on topography. We know that topography gives us the opportunity to see abnormality in a patient with 20/20 distance correct vision with normal biomicroscopy. This is the right eye of this patient. But the fellow eye of this patient that may be called unilateral, and we will address that in a little bit, would be a patient that has a normal topography. So form-fruit keratoconus is an interesting concept that started with Mark Emsler in the literature in the 40s when he described incomplete or abortive forms of the disease. I remember a very good lecture from Jay Krashmer that described form-fruit as a very mild keratoconus. Early is not a good topic, a good description, because some cases will never develop. So mild that could progress or not to the plain or full-blown form of the disease. That's what form-fruit is. Steve Kleiss and others described the fellow eye with no clinical signs of patients with very asymmetric disease. Eventually, they are unilateral in some cases, and we address that in a little bit. But this is all defining form-fruit. And form-fruit is frustrating to be defined because there is no consensus. We tried consensus in the global consensus, in the Latin America consensus. People don't agree what is form-fruit. My humble suggestion is that form-fruit is a patient with high susceptibility for progressing, who may progress or not, depending on the environment. And I came with that proposal about 10 years ago. Understanding that we have to go beyond topography, beyond understanding of the corneal shape in the front surface is understanding tomography. Tomography gives you a lot of information. And patients like that with a normal topography or a relatively normal topography, this will be addressed as an abnormality. When you know this, it's very easy to say this is very abnormal, but in a consensus, I would say this patient would have surgery. We published a paper on the variability of the subjective classifications of corneal topography maps done by experts, and the majority would say that this is a normal in the 0 to 4 Brad-Redelman risk score on topography. This patient had a residual stromal thickness of 300 or more, PTA lower than 0.4, and developed ectasia. And in the pre-op, we were able to detect abnormality on the tomography level. Of course, the back surface is not obvious, but the D is abnormal, the arcmax is low, and those values are very important for me to say ectasia susceptibility. This patient with 20/20 distance correct vision does not have keratoconus. He has ectasia susceptibility. So the major point is that form-fruit is not a topographic sign. We have to recognize the great contribution from Steve Schallhorn that looked at a very high number of cases. And he found cases that developed ectasia with a normal tomography and cases that were stable after LASIK with long follow-up that had impressed abnormal shape in the pre-op. And you see this patient is with a relatively good thickness, but has a very abnormal tomography, even in the back surface. So ectasia is a conundrum. The conundrum is relating to over 10 years, over 20 years of a mystery. And this paper published last year by Dr. Bohak, uh, and she published a series of 10 cases out of 30,000 laser cases that had ectasia. And she was very keen to look at the data preoperatively and finding very little uh, indicators for the risk. So it pretty much makes the point that we have to go beyond. We have an enhanced ectasia study, uh, and over 3,000 stable cases comparing to 100 cases of ectasia. This is not, the incidence is not 100 per 3,000. It's not. We collected the prep data on pentacam and clinical data from 3,200 cases, and we were able to get the pentacam pre-op of 104, 105 cases of ectasia. And you see that age, PTA, and the residual stromal bed are very low, accurate metrics for detecting ectasia risk. This is a very important information. And when we look at the data about topography, the IS value of 1.44, actually 1.45, which is pretty much when we see suspicious based on Yaron Rabinovit's keen publication in 1889, and the bad D, you see even the bad D is not so good. You have, you detect 60% of cases roughly, and with a 10% false positive rate. We improved the algorithms from BAD-D to Pentacam Random Forest Index as part of Bernardo Lopez's thesis of PhD, and the artificial intelligence can do a little better. You improve the specificity and the sensitivity, which is very much significant in terms of statistics, but we still have a huge number of patients that develop ectasia that we cannot detect based on the Pentacam random forest data. However, when we combine the Pentacam random forest with age, flap thickness, ablation, you can get the enhanced ectasia susceptibility score, now going to a good number that I would say it's very acceptable, saying that we have about 7% that will be not detected, but probably those are the cases that rub the eye. And eventually, if you look at bilateral ectasia prediction, all the cases will be detected, because if one eye would be abnormal, you will not operate the other eye as well. And if you apply the both eyes, you lose a little bit of the specificity to about 85%. So it's something that we have already, and it's not commercially available, the ectasia enhanced ectasia susceptibility score, but hopefully it will be soon available. Going beyond on corneal imaging, we have corneal tomography going to the properties. Properties is important. We have done a lot of work with the ocular response analyzer that gives you the information about the corneal reflex. But the Scheimpflug of the horizontal 8 millimeters cornea data gives you much more information. So this very fast, ultra fast camera would give you a lot of information to monitor the deformation, the velocity, the amplitude in the center, in the periphery. And all these were put together in an index that was awarded by the ISRS as the Trotman Award in 17. And I was honored to collaborate with Paolo and Riccardo Vinciguerra from Milan. I hope they are doing well, the true epicenter of the coronavirus today. We've been working with tomography and biomechanics since a long time ago, and this review was from 2011, on which we are predicting the integration of data from tomography and biomechanics. And that was ever possible when both instruments came from the same company, which is the case of the Pentacam and the Corvis. Both are from Oculus, and we developed the algorithms using random forest to combine the data from tomography and biomechanics. We included 96 cases from my clinic and from Vinciguerra's clinic that were normal in one eye on topography. And normality was acknowledged by the objective criteria based on surface topography, KISA, NIS, central K, and no pattern of abnormality detected on the TK see. But if you see some of the cases, they are not so normal. They are not so normal at all. But the subjective was not implied. It was the objective classification. And this was done using the Steve Kleiss 1.5 absolute scale. When you look at the data, it was 480 normals, 204 keratoconus. This is one eye randomly selected from each of these cases. And we have this patients with very symmetric ectasia and the fellow eyes with ectasia that were not operated also entering the study. We have the bad D transformed to the bad DI, which is a parameter from 0 to 1, and this is a perfect correlation because we just wanted to have this distribution to be comparable with the CBI and the TBI, which was the algorithm that we created using random forest with one-out cross-validation. So here, when you look at this data, and I think it's epitomize of the susceptibility score for ectasia at any cornea would have. This is very good for detecting, actually it's perfectly, virtually perfect, as I like to say, for detecting clinical ectasia and enhances the sensitivity for the subclinical cases, considering that all of these cases will be abnormal, which is definitely not the case. And it's challenging because this is a cross-sectional study. We don't have a longitudinal data to say that these patients were stable forever, so they are truly unilateral. But you see some clustering here and some susceptibility happening here, which is something that is highly in agreement with my hypothesis that we have a susceptibility threshold that some corneas would have more or less resistance to undergo ectasia and due to biomechanical failure. So we have to go in external validations, and external validations were done in India, also in Iran, and we see here one of the publications from Dr. Prema from Chennai, and also from Iran with other groups. And we have done in the United States with George Waring IV. My colleague George Haddad got the Colon Award at the ESCRS a couple of years ago, and describing cases like that. You see here with the Atlas absolute 0.5 diopter scale, you see the 0.43 in a patient with 20/20 distance correct vision. And it's important to understand that this goes in agreement with what we have published in the past. This is the fellow eye of a patient that had LASIK only in the left eye. The right eye is normal. We published in 2010 the ORA and the Pentacam data. The ORA lower than 8.8 on the CRF would indicate susceptibility in the right eye. Considering the left eye developed ectasia without an explanation, the patient did not like the result on the left eye and decided not to do the right eye. And she's still stable, and she's a -6. If you look at the Steve Kleiss 1.5 diopter scale, you see very much a green cornea, pretty much a green cornea. And if you see 528 central corneal thickness, this will be a perfect candidate for LASIK. However, looking at different scales, you see the topography scales, Steve Kleiss, this is the Atlas, this is the Ambrosio 2 absolute scale that you can apply on the Keratograph 5, and the PRFI 0.19. And if you see Pentacam is really much borderline to abnormal. However, it makes it even much more clear to see the abnormality when you combine the tomography and biomechanical data and the TBI of 0.78. I could show the patient's son who has a high TBI and a pretty much normal topography, very much similar to this eye in both eyes. And since it's a kid, 11 years old kid, I would say he is a bilateral form fruits case. So it's interesting that we look at that. Bilateral form fruits is also developed in some scenarios like the twin sisters. Here we have the right eye developing keratoconus in the right eye. The left eye is a normal topography or relatively normal topography. The fellow twin has both eyes normal, and you can see again the agreement with the topography with the Scheinflug and the Placido topography, and the TBI is abnormal in all the 4 eyes. Interestingly, ectasia can be unilateral. Ectasia can be unilateral, like one eye has abnormality due to the environment. And this is published in the International Keratoconus and Ectatic Corneal Disease Journal. This is a patient that has the left eye with 20/20 uncorrected vision or better. The patient had a ring in the right eye, did very well. You see the astigmatism reduction to 0.2, and the fellow eye is stable. The fellow eye is stable for over 7 years. One of the follow-ups were done by my colleague and friend, Dr. Dan Ringstein in London, who has a prolific examination platform, including the Artemis, which was normal with the epithelial thickness in the left eye. The Damian, Gatinel, and the Lansad score on the orb scan, also normal. And the patient has a normal TBI. And this was not part of any of the studies, so it's a validating eye for the TBI that was developed in a different cohort of patients. We did a validation study on our populations in Rio, and we published that in the American Journal of Ophthalmology in late 2018. And we were happy with the TBI. However, many cases, like the German study, they found 72% of the TBI with a cutoff that would be even low. And there was an interesting study that I participated in the publication from Japan. And this is something that was very bothersome for us. And we'd like to understand why it happened. And the artificial intelligence gives us the opportunity to keep getting better. So we need to get better. We have to recognize our ability to improve. And the new populations were much more complex. It was a larger population, and we came back to collect more cases of very symmetric ectasia, and we see that this population was something that we could have an opportunity to say, oh, we don't have something perfect. We never claimed that, but now we have the opportunity and the resources to improve it, and that's what we've done. So the area under the curve was actually lower compared to the first study, and we have to improve it. So considering the clinical ectasia, it's already good. So the new populations, the new larger populations, would have the same accuracy for the clinical ectasia cases. This is the group Keratoconus and the VI-E together. However, when we look at the normal topography eye, you see an opportunity here to improve. And pretty much the publication from Germany came with a 72%. And we have the opportunity and the duty to improve. And however, they were selecting those cases as normal topography and tomography based on the BAD-E. And some of these cases were selected tomography and biomechanically normal based on the CBI. So this is a very different situation than when we were before, just trying to find patients with normal topography. They have ectasia in the fellow eye. Now it's a normal topography, normal tomography, and eventually normal biomechanics. So enhanced AI, the optimization is something we did with a larger data. I would not say this is really big data, but it's a larger data. And we have the opportunity to work together with Professor Ideleuza Leão and Aidano from Northeast Brazil in Alagoas. They formed with me the group with Brain, with João Marcelo Lira. And all this work was done to improve the optimized function. And here we have the dot plots of the new function that we developed. And this is further being refined even to further improve it, because we can get better. And we have more data, we can get better outcomes and better prediction. That's exactly on the basis of any artificial intelligence that we do in our lives. And something that it's around us, we cannot go against it. It's something that will be part of our lives in the future. And you see the ROC curves that are pretty much in agreement with what we're saying. It's a much better parameter than what we had with the TBI, which was already better than everything we had, looking at the PRFI, BAD-E, and CBI. It's normal topography eyes. It's something that's better, not perfect, Again, better and not perfect. But some of this very asymmetric ectasia cases with normal topography and eventually tomography, they would be called really unilateral based on the understanding that we have. You see the correlations here. This is the correlation is a very high correlation, but a sigmoidal correlation with the TBI and the new parameter. So the conclusion is that optimization is possible. External validation is important, and we are doing now reverse engineering for testing with fine element models of that. So that's pretty much the end of my first talk. You want to come with any questions?
Okay, thank you, Professor Renato, for this so informative presentation about the TGA, which is one of the most controversial issues in the refractive surgery, and all the time, despite all these guiding lines, but at the end of the presentation, I felt that I got a lot of information which enable me to judge my patients easier and to be more comfortable with them. If I took the decision to do or to cancel, any words.
Good.
Then
So,
let's back to the questions. Even following the bad, which is a Belen Ambrosio display, we may find a lot of cases where there's a yellow sign in the deviation of some of the boxes at the bottom. But actually, when I review all data of this patient, especially correlation with the figure data with clinical signs, I found that I am comfortable to do a surgery for this patient. Otherwise, I may find a display, the deviation of the display is wide, is good, and there is no alarming sign. But actually found this, that there are a lot of points of risk, or risk points in the topography of that patient. So how to deal with such controversial cases?
if you have a friend of mine, he says that if you have a lot of concerns, you should not have a question. You should not proceed. It's
Yeah,
like getting a plane. If the pilot is not confident everything is correct, he should cancel the flight. Of course, the flight will be canceled. You have a lot of downs on that and problems related to that because you have the patient interested in doing surgery and you want to do that. But if you have questions, you should be keen to say no, or eventually do surface ablation and not do the lamellar surgery, which weakens the cornea more. And we can discuss keratoconus treatments and refractive treatments in keratoconus as a different topic. But I would say the issue is the more that we know, the more I recognize and am conscious that we need to know more. And knowing more is epithelial thickness, is enhanced understanding with tomography and biomechanics, wavefront. All this data can do some improvements in your decision-making process. And eventually, that is something we should all be willing to accept the limitations of the progression on the knowledge, the evolution in the knowledge,
yeah,
and of course the need to evolve. So we have the need to evolve because, and we have to understand that we should always keep evolving, and we have to make a decision when is enough for us to make a decision. And if you have all the clues that you need from the exam, you should be more conservative, as you just said, and eventually not doing the surgery, waiting a year or 6 months, and eventually not doing LASIK and doing surface ablation.
yeah,
But uh, the idea is that there is no perfect answer for every case. And even if you want to have the perfect candidate that has like let's start with a thick cornea. Patient is 45 years old. You have -2 diopters, very low weakening, and the patient rubs a lot the eye. He'll develop ectasia.
Yeah.
And so the idea that the risk that we have to address is the risk assessment, and the risk should be acceptable for
Yes.
for everybody to be understanding. And patient education is a must. I do believe patient education, and it's an art as well, because if you go to the explanations, the lecturing of the complications that every patient should be understanding about that, you're probably not going to do surgery in any patient. So you have to be keen enough to tell the patient what they should understand and avoid, and they will be confident on you for making a decision for the best of your knowledge that day with the information that you have that day, so that you can proceed for the best surgery. So that's pretty much which goes into the next uh, point, which is where we are going. We have multimodal imaging helping us making decisions with the artificial intelligence,
Uh,
and
okay.
different things, ectasia susceptibility, impact from surgery, and customization for improving the safety. All this together are going to make refractive surgery even better, and eventually also for therapeutic procedures in keratoconus.
Okay.
Keratoconus has,
But a
okay,
very,
go ahead, please.
yeah, but a very important point you said today that we have to back again to the concentration to a very significant concentration or recommended concentration for the corneal biomechanics. The corneal biomechanical properties should be put in consideration to say this patient is okay for refractive surgery or not. Because 10 years ago, started the corneal biomechanical properties started to put in this concentration and then disappeared again with the aura, the ocular response analyzer. But I think nowadays with the Corpus standard and with the TBI, the subject will be shown in a different way, right?
Uh, yes, the ORA is still good. Ocular response analyzer is still good. The problem is that we have interests, and their interest from the writer company was not to proceed with the keratoconus ectasia uh, studies,
Yes.
and it was at the same time that the Corvus came, and the Corvus was, a long process of developing, and we have new guys coming on the world, coming like the new kid on the block is going to be Brillouin, and probably you'll have other things coming with interference that may come to tell us about mechanics. So it's not one machine or one device or one method, but the understanding of biomechanical properties. And this is unquestionably important. But are we there yet? Yes, I do believe we have made significant progress, which is related to biomechanics and tomography. And artificial intelligence is very much important because we are overwhelmed with data, which we don't have the ability in our minds to make a decision based on the parameters, the hundreds, thousands of parameters that we have from these machines. So we have to understand which parameters are important, which are reliable, and how to use that data so that you can make a decision. But the basic is we have to go beyond, not over,
Yeah.
which is
The last year, I asked Cynthia Roberts. I think you know her. uh,
very well. We collaborate a lot. She's a
yeah.
great friend.
Which one is better, Cynthia? ORA or Corvus? She said ORA is much better in the accurate measurements of the intraocular pressure, while the Corvus standard is superior to the ORA in defining the biomechanical properties and defining the susceptibility for ectasia after LASIK. So she said that. What's your opinion?
You know, ORA is different than Corvus. Uh, the, I worked a lot with Riker,
Yeah.
and I remember when Dr. Luce, who is the inventor of the ORA from Riker, he passed away a few years ago, was also a great friend. When he was explaining me that we should understand the corneal properties to understand the pressure,
Yeah.
because your array is both of them are tonometers. They are for measuring intraocular pressure, and the ORA was developed to improve the understanding of intraocular pressure based on the corneal hysteresis, which is the first parameter that was developed. Is on his observation that the P1 is always higher than the P2, so we have that second peak, and the difference would be. And I told him that I think it's important to understand the pressure, but I want to have this parameter for understanding LASIK uh, procedures when we should not do it when patients at risk. And it was fascinating because at that time we were talking probably 2002 or 2000, yes, 2002 for sure. And it was not under ideas to develop a system for that. And eventually, when the array came first, the refractive surgeons were the first ones to look at that and to embrace that. Of course, glaucoma colleagues are more conservative in terms of adopting new technologies. And then hysteresis came as a very important risk factor for glaucoma to progress. We have the IOPCC, and we have much more developments based on the ocular response analyzer for IOP.
Yes.
But based on what we have today, the Corvus is as good as or even better than the ORA also for the IOP
Might be
measurements and for
measurements.
glaucoma. We
Yeah.
have the glaucoma predictability score based on a very large study done looking at the normal tension or so-called normal tension glaucoma cases.
Yes.
And this is something that we can learn a lot from. It's like the very symmetric ectasia cases, but like the very symmetric ectasia cases that some of them may be unilateral, the normal tension glaucoma, they may have some other things. And it's even interesting to see the discussions about how to define this group. But I would say that the
Yeah.
Corvus is a more complete machine, but there is a basic difference, which is very important that everyone should understand. The peak of the curve of the air pressure that goes against the eye is different in every measurement of the RA. The puff, because the first applanation signals back to the nozzle
Yeah.
to stop the peak. And the Corvus it is standardized and it is fixed. So it's a very big advantage to have it standardized so that all the measurements are compared to the same deturbation of the cornea. And that's very important.
Okay, so I have a lot of